see how I can. So I'm a little bit low on my Mac battery. I'm sorry, I was actually supposed to be on vacation and I had to come into the hospital. So my day is a little messed up today. But if I'm out of battery, I just may need to switch computers, but hopefully I'll be okay. Any issues with the volume or slides, please let me know. Again, my name is Tamit Contractor. I graduated from MSU 2011. Me and Supratik were batchmates at that time, so it's been a long time. I've always wanted to visit, but somehow something or the other kept happening, life, work, and then now the pandemic. But it's good to be there virtually anyway. Here are my disclosures. Should not be very relevant to this talk, these disclosures, but I'll just leave it up there for a second. So again, this is a very basic talk, and maybe it'll be more helpful to the first years, but just a very brief kind of 10,000-foot overview of atrial fibrillation and atrial flutter. We'll talk about the epidemiology, etiology of atrial fibrillation, of what are the different types of atrial fibrillation and how do patients typically present. We'll also speak about management, both acute and chronic management, and then a few slides on atrial flutter. This is a talk I gave to the residents at Loma Linda, so it's a little bit geared towards the residents. And I also have some board-style questions in there, so hopefully you'll find it useful. What is atrial fibrillation? It's the most common arrhythmia in adults. This is, you all will see it left, right, and center, in your careers. But the basic definition is it involves a very a lack of organization of any atrial activity, where you'll see these fibrillatory waves going on in the background, and then you'll see typically irregular ventricular complexes, where the AV node tries to block most of these impulses that are bombarding the AV node, these AF wavefronts, but it lets few of them through. And based on how many are let through, the rates will either be very fast, very slow, or controlled. As I said, it's the most common arrhythmia that's seen in adults. In patients that are more than 40 years old, the lifetime risk of getting atrial fibrillation is approximately 25%. More than 80 years old, 10% of the patients will have atrial fibrillation. It's associated with an increased risk of stroke, heart failure, as well as dementia. Which brings us to our first question. And again, this is board style, straight from MixApp. This is a 55-year-old woman that's evaluated after a recent hospital admission for ischemic stroke. She presented with right-sided hemiparesis, but it completely resolved after the second hospital day. An ECG, echo, as well as ultrasound of the carotids was normal. She had a transesophageal echocardiogram, which was also normal. She has a history of hypertension for 10 years that's well treated with hydrochlorothiazide. On exam, she has normal vital signs. The exam is completely normal, regular rate and rhythm. CNS exam is also non-focal. No issues whatsoever. There's no edema. She has a 12-lead ECG that shows normal sinus rhythm. And the question is, what would you do next? Would you do antiphospholipid antibody testing? Would you do a left heart catheterization? Would you do a 30-day event-triggered loop recorder, or would you do a 48-hour Holter?
Lisa, do you want to answer this one?
Yeah, I mean, yeah, I can answer it. I should have maybe told you all this, and maybe we could have had a poll set up, but yeah, I can go ahead and answer it. Bottom line, if patients are more than 55 years old and they have what is called a cryptogenic stroke, and a cryptogenic stroke means you haven't found an obvious source, like a vascular source in the carotid arteries, or an obvious thromboembolic source coming from the heart, for example, a cardiac myxoma or a left atrial appendage thrombus. If there's no obvious cause like this, then we typically call it cryptogenic stroke. And the definition of cryptogenic stroke based on how much workup you do has been a little bit variable in the literature. But if you look for atrial fibrillation in these patients that are more advanced stage with this cryptogenic stroke, you can find Afib in approximately a quarter of the patient. Some would even argue not to do a 30-day monitor, but to do what we call as a loop recorder. A loop recorder is like a small device that we inject below the skin. It has a battery life of approximately 2 to 3 years. So it will monitor your heart rhythm for that time. And it has specific algorithms that can detect irregularity in the heart rate and can flag episodes that can be atrial fibrillation, which the physicians can then review. And if they truly have Afib and now with a prior history of stroke of no cause, you can start the patient on anticoagulation. So this will be expected for you to know atrial fibrillation, common risk factor for stroke. Patients may not present an atrial fibrillation when you see them, but may have had atrial fibrillation before or after you see them. And you would have to, keep an eye out for this. There are many etiologies of atrial fibrillation. The one I've put in red is issues related with lifestyle. So obesity, diabetes mellitus, hypertension, coronary arterial disease, and sleep apnea. All these can be in a way reversible with exercise and diet control. The other thing we see, not very commonly like in all patients, but we do see it once or twice a year, is that the patients present with either significant hypothyroidism or hyperthyroidism with atrial fibrillation. And it's just good to check a thyroid in these patients just to make sure that is not an issue. Where we stay in California, there is a huge proportion of patients that use amphetamines. So we see a lot of patients with amphetamines that present with arrhythmias. And obviously alcohol and excessive caffeine, either in the form of coffee itself or now more recently, these high caffeinated energy drinks are also common risk factors for atrial fibrillation. So when you see patients that have had or having atrial fibrillation, we should try to address some of these risk factors. Acutely, you'll see them in your ICU rotation. You'll see patients who have acute anemia or sepsis or a massive PE or have had recent cardiac surgery get atrial fibrillation. Thankfully, these are related to acute etiologies. And if you fix these acute etiologies, these are typically short-lived. Some patients may need beta blockers or antiarrhythmic short-term as they are recovering from these acute illnesses. What symptoms will patients present with? A lot of these patients can be asymptomatic. They have a routine ECG and then their atrial fibrillation is found. But we do see a lot of patients that have significant symptoms that correlate with them going into atrial fibrillation. And there's a host of different symptoms that I've listed there. Some patients won't have any symptoms at the outset, but as they remain in atrial fibrillation for a long time, especially with elevated heart rates, their ejection fraction can drop. And that is what we call is atrial fibrillation induced cardiomyopathy or tachycardia induced cardiomyopathy, where related to the high rates and also the irregularity in the rates, the ejection fraction can drop. And it's actually a good sign if patients have this, in the sense that if you control the arrhythmia, control their rates, and especially if you get them back in normal rhythm, we have seen many patients where the heart function completely recovers and there is good reverse remodeling in these patients. As we saw in that case, some patients can even present with stroke at the first time, as the first sign of atrial fibrillation. So you might see a patient in the stroke unit, no prior history, that have a massive MCA stroke and also have atrial fibrillation with rapid rates. And that may be the first time it's diagnosed. In these patients, we struggle about when to start anticoagulation because there is a risk of a conversion to a hemorrhagic stroke if you start anticoagulation very soon. And you have to talk to the stroke physicians about how big the stroke is, what is the size of it, etc., to decide on when it would be an appropriate time to start anticoagulation. We classify atrial fibrillation mainly based on duration currently. So if the atrial fibrillation lasts for less than 7 days, we call it paroxysmal. If it lasts for 7 days and if it needs a needs either amiodarone or electrical cardioversion to convert them to normal rhythm, then we call it persistent. If atrial fibrillation lasts for more than a year, but there is still hope, if there's still hope and, sorry, just got a call. If there is still hope and a chance that you may try to restore normal sinus rhythm in this patient, we call it long-standing persistent atrial fibrillation. And if a patient has been in atrial fibrillation for a long time, the rates are controlled, don't have symptoms, the patient and the physicians together may decide to not to pursue a rhythm control strategy, to leave them in atrial fibrillation, and we would call that permanent atrial fibrillation. The other way to classify atrial fibrillation is whether it's related to valvular heart disease or not. So if patients have moderate to severe mitral stenosis, or they have a mechanical mitral valve, specifically a mechanical mitral valve, then we would call it a valvular atrial fibrillation. And otherwise, we would call it non-valvular. And this would have implications in the choice of the anticoagulant you use. So I will get to that later. There is a progression among types. So you can imagine someone with a healthy atrium who's just having many, few short episodes of atrial fibrillation. And then as time goes on, they have more and more atrial fibrillation. If something is not done, if a rhythm control strategy is not pursued, if risk factor modification is not done, this time in atrial fibrillation just keeps increasing to a point that they are in atrial fibrillation all the time. And it's not just the rhythm that's changing. As the heart remains in atrial fibrillation all the time, the atrial structure and function also changes. There's increased amount of scar in the atrial tissue. The size of the atrium also increases. And so the chance of going back in normal rhythm keeps decreasing as patients have atrial fibrillation for a longer time. That's why there's a classic adage in medicine called atrial fibrillation begets atrial fibrillation, and that's where this comes from. It sets up a vicious cycle. And so that's why for many of these patients, especially if they are symptomatic, young, and have evidence of heart failure, it's important to pursue a rhythm control strategy very early to prevent this progression of substrate. In terms of acute management, if a patient is in atrial fibrillation and is not stable, blood pressure is low, and they are dizzy, lightheaded, then the best way to take care of it right away is to cardiovert the patient. If it has lasted more than 48 hours, or you don't know how long it is, or you don't know how long it has lasted, then ideally you want to rule out a thrombus in the left atrial appendage. A lot of patients with atrial fibrillation, especially if it's not related to a valve, will develop thrombus, specifically in this outpouching of the left atrium called the left atrial appendage. And either with the help of a CT scan, but more commonly with the help of a transesophageal echocardiogram, it would be good to rule out a left atrial appendage thrombus before you cardiovert them. Sometimes you don't have the luxury to do that if the blood pressure is very low and patients are unstable. Prior to a cardioversion, you always want to start these patients on anticoagulation, and you want to continue anticoagulation for at least 4 weeks after a cardioversion, especially if the Afib has been for more than 48 hours or you don't know how long it's lasted. Brings us to question 2. A 79-year-old woman is evaluated in the ED for palpitations that occurred intermittently for the past 48 hours. She has a history of hypertension and hyperlipidemia. She's on low-dose aspirin, atorvastatin, and lisinopril. On exam, her vital signs are okay, except her heart rate is 110 beats a minute with intermittent irregularity. The CVP is normal. The heart rate is fast and irregular. Lung fields are clear. Extremities are warm, well perfused, no edema. And this is her ECG. And what would be the most appropriate next step in management? Beta blocker therapy, anticoagulation, IV adenosine, IV procainamide, or urgent cardioversion. And I'll just leave this ECG up. I don't know if any of the senior residents want to speak up and take a stab at this.
C1, do you want to? Yeah. Do you want to see the question? They're asking to see the question, Sam, Dr.
Oh,
Contact.
sorry.
Yes.
I went through quick.
I think they wanted to see the vitals as well. Yeah. Because the microphone is on here, so if you want to just come up here.
All right, so it looks like this patient kidney fit in Afib with a hemodynamically stable, blood pressure is stable, and the pulse rate is 110. And can I have a look at the EKG? So this has been occurring more than 48 hours. That's what we know. And looks like here, so the rhythm is irregular, definitely. I couldn't really see the P wave per se from here. Okay, and what are the options for the answer again? So I'll just go on to rule out the answer. So the patient is hemodynamically stable right now, so urgent cardioversion might not be the best option right now, especially it's more than 48 hours too. IV procainamide, I don't think that's the first line that we usually use for AFib too. And IV adenosine, usually when we're unsure if it's as SVT, they usually use that. So I will probably go for beta blockers and anticoagulation at this point.
Yeah, that's great. That's exactly the answer. Just want to focus on the ECG for the first years. You know, you can see actually, we don't see this very commonly on ECGs, you know, that you can see the onset of atrial fibrillation. So you can see the first beat here is actually a sinus beat. I hope all of you can see that. There's actually a P wave over here that's upright in lead 2 and even in lead 3, lead 1. So this is most likely a sinus beat. And following that in the T wave, you see there is something there. It doesn't look okay. So there's probably a PAC, and that's how atrial fibrillation typically starts. There's typically a premature beat that puts people in that starts out and puts people in AFib. So, I'm so sorry. I'm going to have to switch out here. My battery is really low, and I forgot my charger. So, while I'm switching up, it should take me a couple minutes. If anyone has any questions, I'm happy to answer them. Any questions whatsoever, even if we haven't spoken about it yet.
Okay, Doctor, I have a question that we haven't touched base on is initial management with AFib people, especially in the ER, new onset on the floor, that you don't really have history about their ejection fraction, about their heart failure status. At least here, I've seen a lot of people use cardism on these patients. I feel like they shouldn't, but I'm not sure what you think of this. Like a beta blocker would be a safer option than a calcium channel blocker.
Yeah, I guess the question you may be asking is a lot of these patients may have a low ejection fraction, right?
Correct.
So
correct.
Just to clarify for the first years, I think what you're trying to ask is if patients have a low ejection fraction, you don't want to give cardism, which has a negative inotropic effect, right? And typically, the classic teaching is you don't want to give cardism for patients with heart failure because of poor outcomes. I think, one of the things we have to realize is IV amiodarone is also a negative inotropic agent. IV beta blockers are also negative inotropic agents. All of these are negative inotropic agents in a way. The one issue I see with cardism is, especially if the ejection fraction is very low, and the half-life of cardism is much longer than, for example, esmolol. And so it can accumulate, and now the patient's heart rate is okay, but now the blood pressure starts dropping, and then you have to stop the cardism, and then you have to wait a long time for the cardism to wash out. So that is one of the problems I see with cardism, that I don't like to use it as a first line for my, when I see a patient in the ED. I'd rather use something like esmolol, which is much shorter acting, till I can figure out what I'm going to be doing with this patient, TE cardioversion or IV amiodarone, etc. I don't know if that answers your question, but yes, there is a lot of patients who, a lot of physicians who reach out to cardism as a first line. I think they are much more comfortable with it. They've used it a long time, but I think while we get like dogmatic about it, about not using it in heart failure patients, I think we have to realize that amiodarone and esmolol also have negative inotropic effects. So if you're using something short term, then why not just use cardism? That would be the counter argument.
Okay.
It just lasts longer and drops blood pressure. That's why I don't like it. I typically use esmolol if I see a patient in the ER and I'm not sure where I'm headed with them.
Yeah, the thing here, because of esmolol, it's a drip, so it's only in the ICU. Like if you start esmolol, the patient will end up in the ICU, so it's less commonly used.
So cardism, what they typically give a bolus then, or they start a drip for you guys?
Both, because they can like the nurses on the step down can manage a cardism drip, but they cannot manage an esmolol drip.
Yeah, and that's crazy, right? Like if you think about it, I've had a patient in my second year of residency at MSU. I had a patient die from cardism drip. Like the nurses did not check her blood pressure for a long time, and she was like semi-comatose, and no one checked on her, and she actually died.
Kind of something similar happened like maybe 9 months ago. I was covering in the ICU and the same thing happened. Patient came in, Afib RVR, some signs of heart failure, was starting cardism drip and arrested in the ER, and they don't really know what happens, but it's kind of one of the things where maybe cardism was not the best option.
All right. Sorry, I'm back on my new computer. I am on my office computer. I just need to open up the PowerPoint.
For patients who we have recorded in, or maybe an event monitor for 30 days, and you have an AFib burden that's not super significant, maybe like 1%, 2%. And let's say this was put in for maybe a cryptogenic stroke. Do you have like a cutoff for the burden of AFib for when you would consider, antiarrhythmic or anticoagulation, or is it going to be more case-to-case kind of individualized decision making?
Yeah, if it's put in purely for cryptogenic stroke, right? If you put in a loop recorder for cryptogenic stroke, our threshold is very different to start anticoagulation. We typically 30 seconds of AFib is sustained AFib, right? So to say. So if someone truly has cryptogenic stroke, young patient, you don't want them to have a stroke again, and now you see 2.5 minutes of AFib, I don't think anyone is going to argue that they need anticoagulation. The bigger problem happens when you see a patient who's not had a stroke, now has a CHA2DS2-VASc score of 2 or 3, and now someone has put a loop recorder for some other reason, like they're passing out or having palpitations, or they have a pacemaker or a defibrillator, right? And now you're getting all this information about AFib. What are you going to do with 5 minutes of AFib? And that's a tough question. When I was a resident, I wrote a review article 10 years ago on this. When I was at MSU, and there's still no answer after so long. There's still no good answer. The best we know is that once it crosses 24 hours, that's typically a very high risk, and we would typically recommend anticoagulation. If it's less than 6 minutes, it's typically okay. Between 6 minutes and 24 hours is highly individualized, and it would depend on the CHA2DS2-VASc score. Someone with a very high CHA2DS2-VASc score, even with 15 minutes of AFib, we would do anticoagulation. But there's a lot of time spent in clinic and what we call shared decision making, where we discuss with patients and what are you more scared about? Are you more scared about bleeding with anticoagulation? Are you more scared about stroke? And most of the patients know exactly what they want. Sometimes it's hard.
Right, that makes sense. Thank you.
Great questions. Let me try to share my screen again here. Are you able to see my?
Yes, we see the presenter's view.
So that's the wrong view, right?
Yeah.
Oh. Okay. So again, in terms of acute management, you obviously want to rule out reversible causes, which we already discussed. If you, especially if you want to rule out a thrombus, you would want to do a TE. But in most patients, you would want to get an echo to see if they have any significant valvular heart disease that's contributing to the AFib, if the ejection fraction is low, etc. When would you cardiovert a patient? Again, if the patients are very symptomatic or rates cannot be controlled despite multiple meds, or if their EF is low, you really want to get them back in normal rhythm. You can either do it electrically or pharmacologically. I see this all the time. Patients have been in AFib for a long time. They have rapid rates and people just start them on amiodarone. They don't think the same way that starting someone on amiodarone is almost the same as doing an electrical cardioversion. They can convert with amiodarone. And during my fellowship, we did have a case where someone started amio, patient converted, and then had a stroke. So just think about it when you just start IV amiodarone on someone that presents with AFib that is, of unknown duration or more than 48 hours. Sometimes you have to, there's no option, and that's okay, but at least think about the risk of stroke. And if possible, if you can do a TEE, that would be great. A CAT scan can also be done, but typically in my experience, for getting good CAT scan images for the left atrial appendage, the rates have to typically be well controlled, like 60s or so. And most of these patients in whom you're considering a cardioversion have very rapid rates. And so CAT scans usually have not helped me in these situations. Again, before you cardiovert them, always give them heparin or whatever, Lovenox, some anticoagulation, Eliquis, and then irrespective, at least for me personally, even if I see a 28-year-old patient that had AFib for 12 hours and is now in the emergency room and I'm going to cardiovert him, I typically always put them on anticoagulation for at least 4 weeks because I feel like, the risk of stroke, even though if it's low, the implications of having a major stroke from AFib, especially in a young patient, is just so high. And the risk of bleeding, especially in a young patient, is not that high. So in terms of competing risks, for most patients anyway, I will always anticoagulate for 4 weeks, irrespective of their CHA2DS2-VASc score and irrespective of the duration.
Do you do that even if the patient spontaneously cardiovert?
So that's it depends how long the AFib has lasted. If the patient spontaneously cardiovert, I will have a discussion with them. But if I'm electrically cardioverting them, it's somewhat of a ownership responsibility now. It becomes kind of your fault, unfortunately, if something happens. So yeah, in those people, I will push a little bit more for anticoagulation. If someone just came in and spontaneously converted and they have a low CHA2DS2-VASc score, I will have a discussion with them and decide what to do. Good question. CHA2DS2-VASc score is something you'll all need to know. As soon as you see a patient with AFib, you have to think about their CHA2DS2-VASc score. That's just something that has to come second nature. So for the first years, just make it part of your habit. If you write AFib on a problem list, the next point should be CHA2DS2-VASc score. Obviously, unless they are in the ICU and are septic, then it may not matter. But if you're seeing someone in clinic or on the floor, it's critical because the CHA2DS2-VASc score is the best score we have to predict, the risk of stroke. And these are the typical factors we have. If someone has a prior stroke or TIA, we give it the most importance. We give 2 points. Age, we give either 2 or 1 based on the age. And then all these other factors have, 1 point each. And then based on that, you can have a score and then an according, risk of stroke. But typically, obviously, if your CHA2DS2-VASc score is 0, your stroke is less than 1%, which is kind of the background risk of stroke. If your CHA2DS2-VASc score is more than 2, that's typically enough criteria to start anticoagulation. It's more than the background risk. And then between this 0 and 2, which is a CHA2DS2-VASc score of 1, it can sometimes get tricky. And because now the risk is somewhere in that gray zone, but it's still higher than the background risk, but may not be high enough where anticoagulation may help. And that's where the guidelines are a little nuanced and a little more shared decision-making has to be had with patients. Which brings us to question 3. A 75-year-old woman is evaluated during a routine visit. She has a history of hypertension and CAD. She had a stent placed 5 years ago. She has no symptoms. She's on metoprolol, lisinopril, aspirin, atorvastatin. On a physical exam, her vital signs are overall normal. However, the pulse is irregularly irregular. She has no other significant problems on physical exam. ECG shows atrial fibrillation. And what would be your next step? So again, just to recap the question, kind of paraphrase it, this is a woman already 75. So CHA2DS2-VASc already 3. Now you add hypertension, coronary artery disease. CHA2DS2-VASc is 5. And she has atrial fibrillation, first time diagnosed, no symptoms, rate controlled. Prior history of CAD and stent, already on aspirin. What would you do next? Would you add Plavix to aspirin? Would you just add oral anticoagulation? Would you discontinue aspirin and then begin Plavix and anticoagulation? Would you discontinue aspirin and begin oral anticoagulation, or you would not change therapy? Don't know if someone wants to take a stab at this.
Sharia, do you want to take a stab at this question?
So I was gonna go with B. I would keep the aspirin and add the Eliquis. I think she has a history of CAD. The aspirin helps with the platelet side of things, and the Eliquis or Xarelto with the NOACs, or Coumadin if that's recommended, to take care of the risk of clots and stroke in AFib. At least that's my basic understanding of it.
Oh, that's great. I think all of y'all are very good. That's absolutely what I would do too. I mean, you can just go through the other options for the sake of maybe the first years is adding Plavix to prevent the risk of stroke related to atrial fibrillation has been studied. Aspirin and Plavix versus Coumadin, and definitely anticoagulation, either with Coumadin or now the newer oral anticoagulants, which we'll talk about, has won. So adding Plavix is not going to help decrease the risk of stroke with atrial fibrillation. The option number 3, which is to stop aspirin and begin Plavix and anticoagulation, may also not be necessary if they are doing stable on aspirin. You don't need to switch the antiplatelet agent. We sometimes do this fresh after a stent. So for example, if this patient just had a stent, right? You saw this patient in the hospital and they just had a stent, and now they have to be on aspirin and Plavix, and you also want to put them on anticoagulation. What we can do, based on the findings of one trial, is keep them on triple therapy for a month, and then switch them to Plavix and a NOAC, or Plavix and warfarin thereafter, so that the stent remains open and the risk of stroke with atrial fibrillation decreases. Option number 4, some may consider reasonable, like the data for stable vascular disease and continuing aspirin has been questioned by some. In some very high-risk patients for bleeding, we might consider stopping aspirin, but in most patients who are not having major bleeding issues, have prior stent, to continue aspirin and antiplatelet agent, and then also start anticoagulation to decrease risk of stroke, like Sharia said, is the most reasonable thing. And then last option, no change in therapy, is absolutely not the right thing to do in a patient with CHA2DS2-VASc of 5 and AFib. If she has a stroke, it's really going to be bad, because again, strokes with atrial fibrillation are major life-altering strokes, and so you don't want to miss an opportunity to start anticoagulation in these patients.
Dr. Kochakar, I have a quick question. It's a little bit maybe beyond what we discussed so far, but this patient kind of fits, like, would you consider this one for like a rhythm control strategy, especially that she fits the East-AFNIT criteria, or would just still keeps on the rate control of the metoprolol? What would your approach be?
Yeah, the thing in her is we don't know how long she's had AFib. That's the problem, right? Okay. Don't know how long she's had AFib. So in terms of East-AFNIT, I mean, she's rate completely controlled, completely asymptomatic. Don't know the duration. I will talk about it a little more maybe when we come to the rhythm control part. I'll try to answer this question. Okay. In general, the studies and everything, all the literature is moving towards a rhythm control strategy. When I was a resident, there was this Affirm trial. That, rate versus rhythm control, it's both fine. Patients do the same. But, there were a lot of flaws with that study. a third of patients in the rhythm control arm were actually in AFib, and a third of patients on the other side were in sinus rhythm in the rate control arm, and so it became very difficult to compare the two groups, and the rates were kind of all over the place in the rate control arm. And so in general, since that trial, a lot of studies have been done, especially in heart failure patients, where a rhythm control strategy has shown to be beneficial. There's no question about it. Whether all comers, any patient with stable rate control AFib, no symptoms, that's still up for debate. I don't think we know. If I see a patient who's in AFib for 5 years, has large atria, completely asymptomatic, goes on the treadmill and is doing fine. I don't know if I have any data to tell that patient, hey, let's get you back in normal rhythm, you'll feel better. So there is that component. Now, I would try to objectify this patient's symptoms. So a lot of patients will get used to being in AFib and lack of AV synchrony. And I would do like a metabolic stress test or an exercise treadmill. I would really want to quantify how they feel in AFib. And if they go for 2-3 minutes on the treadmill and they stop, then that's not good. Then I will try to talk to them about at least considering a cardioversion and short-term amiodarone to see how they feel in sinus rhythm. And if they feel good, then potentially consider an ablation for more long-term rhythm control.
Thank you.
But I'll talk a little bit more when we talk about the rhythm control. Getting back to chronic anticoagulation, who gets it? Again, if someone
Dr. Contractor?
Yeah.
I had a quick question too. I know we're talking about Chad's Vasc, and I always thought Chad's Vasc was better than Chad's, but I was reading an article that was discussing both of them. I was just wondering, is it correct to assume that Chad's Vasc is better than Chad's because there's more variables involved, or?
Yes, absolutely. I mean, you will, I'm trying to think of a 65-year-old female that has peripheral arterial disease. 65-year-old female having peripheral arterial disease will be a Chad's Vasc of 3 with 4% risk of stroke, but on the Chad score it will be nothing. It's so, I mean, you won't really see a female like that probably. It's not very common to see someone like that, but there are many patients who would not fit the bill otherwise for anticoagulation. So Chad is really a refinement of a Chad score. In today's day and age, I don't even think we should discuss Chad score. Like, I don't even put Chad score anywhere. There's no room for it. It's out.
Okay. Thank you.
I hope we get to a point where people don't even remember what Chad score is. We're going to get there soon. But anyway, so yeah, Chad's Vasc score of 2 or greater in men or 3 or greater in women, you get anticoagulation. That's a class 1 recommendation for the guidelines. If someone has a Chad's Vasc score of 1, for men, 2 for women, then you can consider anticoagulation. It's a class 2B because that's that gray zone kind of area. And Chad's Vasc of 0 in men or just 1 in women, which means that they don't have any other risk factors except that they're female, then it's reasonable to omit anticoagulation. And that's a class 2A because there's no real data for it, but it's reasonable to omit it for most patients. And again, these are where you have to discuss the class 2A and the class 2B with patients. And some patients are so scared of having a stroke that if they might elect to still take anticoagulation. And valvular atrial fibrillation. And now, when I was a resident, there was a lot of confusion about what is valvular AFib. For example, if someone has severe AS and got a TAVR, got an aortic valve replacement with the biprosthetic valve, they have valvular disease. And now if they also have atrial fibrillation, is that valvular AFib? But the more recent guidelines have clarified this. So again, if someone has moderate to severe MS, mitral stenosis, or if they have a mechanical mitral valve, this is what is considered valvular atrial fibrillation. In these patients, there is no data for the safety of using the newer oral anticoagulants, the newer ones that are the non-warfarin ones. So in these patients, you would still anticoagulate with warfarin. So for example, if you see a patient with a mechanical mitral valve who also has atrial fibrillation and who doesn't want to take Coumadin anymore because he's like sick and tired of going to the INR clinic, you know, unfortunately, there's no option for this. I still get messages from, you know, from primary doctors that, oh, we are going to switch the patient to Eliquis, and then, you know, we have to stop them. So again, it's very important for you to know this, that if someone has a mechanical mitral valve, unfortunately, the only anticoagulant they can take is warfarin. Moderate to severe MS for that, you know, is not very common. You won't see it very routinely, except in the very, you know, very old patient that is very frail and is not a candidate for any surgery. So you don't typically see it, but you will see the mechanical mitral valve patient that has atrial fibrillation. If patients have non-valvular AFib, so if someone does not have mitral stenosis, does not have a mechanical mitral valve, so someone has a bioprosthetic aortic valve and has AFib, there's actually data to suggest that NOACs are better. And so the guidelines would recommend NOACs over warfarin. Again, NOACs, they used to be called, you know, novel oral anticoagulants, but, you know, now they have been here for more than 5 years. So some people even call them the non-vitamin K antagonist oral anticoagulants to still keep the acronym. But so the NOACs are recommended over warfarin for patients with non-valvular AFib. Valvular AFib is anticoagulation with warfarin only. This is just, you know, I'm not going to go through this in detail, but there are lot of such articles that have shown the different properties of the 4 newer anticoagulant agents, comparing them to Coumadin. Most important I want to highlight is that most of them are excreted through the kidney. So if you see these patients on any of these NOACs, you want to make sure that their renal function has been assessed in the recent past. And if you see them in clinic and they've not had a renal function assessed in 1-2 years, you might want to check it just to make sure that you know, the renal function has not been hampered due to diabetes or hypertension, and now they are at risk for bleeding. The half-life of these agents is typically very short. So if you stop it, it typically gets out of the system, you know, in 2 days. By 4 half-lives, most of it is gone. So you know, that's the good thing about these, as opposed to Coumadin that has a very long half-life. And then the dose is variable. Some of it is dependent on the renal function, and for some of these agents dependent on the age. So just have to keep an eye out for these. I think Eliquis is probably the most commonly prescribed for some reason. I don't completely understand why, but it's the most commonly prescribed NOAC. If someone has age greater than 80, weight less than 60, or if the creat is more than 1.5, 2 out of 3 factors, if they are present, then they have to take the lower dose. So again, if you see these patients, make sure that they are on appropriate dosage of the medication. What if patients cannot tolerate anticoagulation, especially if patients have a CHA2DS2-VASc score of 3 or greater and they are high risk for bleeding? There is this device now known as the Watchman device, the left atrial appendage occlusion device. Like I said, in patients that have non-valvular AFib, most of the thrombus comes from this outpouching of the left atrium called the left atrial appendage. And so if you isolate this outpouching from the rest of the left atrium, the hope is that you decrease their risk of stroke. And so especially in patients who cannot tolerate anticoagulation, because every time they take it, they end up in the hospital requiring blood transfusion, then putting a Watchman device is very reasonable. This is what it would look like on a CT scan. This is just a CT demonstration of what it looks like. Oops. Paged. Are you all still able to see my screen? I'm sorry, something happened to this.
Yes, we are.
After implant, we typically keep them on anticoagulation for around 6 weeks, and then dual antiplatelet therapy for 6 weeks thereafter, and then only aspirin. So we cut down this lifelong risk of bleeding with NOACs to a very short amount of time. You'll be seeing this more and more. I'm sure at MSU and Sparrow, they do a lot of these devices. I can't imagine they don't. And this is just some of the data in that favor Watchman has been compared to Coumadin. There are some ongoing trials where it's being compared to the newer oral anticoagulants. And in general, the risk of bleeding in the brain or hemorrhagic stroke is obviously lower with Watchman. But the risk of other strokes, ischemic strokes, is kind of comparable. A little bit less favoring anticoagulation, but still kind of comparable between the two. So yeah, patients high risk of bleeding, high risk of stroke. Think about this for your patients. What would you do, rate or rhythm control? I think we touched on this briefly in one of the questions, but if someone has symptoms despite rate control, you see them in clinic, their heart rate is 70, but they just don't have energy that they did a year ago when they were in sinus rhythm, then you would want to do a rhythm control strategy. You also want to confirm that they're appropriately rate controlled. So a lot of people sitting in front of you will have a heart rate of 75, 80, but the minute they stand up, it goes up to 120 just by standing up. And so doing a Holter monitor or a stress test to assess rate control is also reasonable in these patients. If patients are very young, if you see a 35-year-old that was in sinus rhythm 2 years ago and now is in AFib, you really want to leave them in AFib for the rest of their life. And again, this is a philosophical question, but most patients would want to go back in normal rhythm. And so especially if they have maybe some symptoms, you would want to pursue a rhythm control strategy. If you can't achieve rate control despite your medications, or if they're having side effects with medications, you obviously want to try to achieve a rhythm control for these patients. If they have evidence of a drop in EF, either from atrial fibrillation itself, or even if they have EF drop from something else, just regular congestive heart failure from coronary arterial disease, these patients do better with a rhythm control strategy. And in these patients, we really like to achieve a rhythm control if we can. In general, two options, antiarrhythmic medication or procedure, which is ablation. When I was a resident, the ablation literature was just coming out, but in the last 10 years, we've gone a long way with atrial fibrillation ablation. It's become much more straightforward, safe. This is the typical strategy for atrial fibrillation ablation. There's the four veins, the pulmonary veins that drain into the left atrium. It is felt that PACs, just like we saw in the ECG in one of the questions, PACs coming from these veins is what puts people in AFib. So if we can somehow electrically isolate these veins so that these PACs can't get out and cause AFib, patients will mostly remain in normal rhythm. That is kind of the hypothesis and the strategy for this ablation. So using either a radio frequency catheter that heats and kills tissue, or a freezing balloon called the cryo balloon, we electrically isolate these veins so those electrical impulses cannot get out and cause atrial fibrillation. While that strategy works for paroxysmal AFib, where the atria are still healthy, there's not much fibrosis and scar in the atria, that strategy may not work so much for patients who've been in AFib for a long time, especially if they've been in AFib for more than a year, because like I said, the heart remodels. And so in these patients, sometimes a lot more ablation is required, sometimes requiring more than one procedure, where several different lines are created across the atrium, almost chopping the atria into small electrical islands so that the likelihood of sustaining atrial fibrillation decreases. Which brings us to question 4. The 63-year-old man is evaluated in the ED for progressive dyspnea. He reports difficulty in breathing laying flat. He had a history of atrial fibrillation and underwent an ablation a week ago. He has a history of hypertension. There's no history of heart failure or LV dysfunction. He's just had an ablation, so he's obviously on anticoagulation with warfarin, and he's also on dronabinol as a rhythm control strategy to help the atrial fibrillation ablation lesions heal up, and on lisinopril for hypertension. On exam, his normal temperature, blood pressure is slightly low. Pulse rate is 112 beats a minute. Respiratory rate is 16. Pulsus paradoxus, which is a difference in the blood pressure with breathing in and breathing out, inspiration and expiration, is 12 millimeters of mercury. Typically less than 10 is okay. More than 10 is abnormal, which means that there is some issues with filling into the chest. Oxygen saturation is okay. Cardiac examination reveals elevated central venous pressure, and you can barely hear the heart sounds. Not much crackles on lung exam. ECG shows sinus tachycardia. So his heart rate is high but regular. Sinus tachycardia. Just to kind of paraphrase this patient, 63-year-old male, underwent a recent ablation, is on anticoagulation, has sinus tachycardia, low blood pressure, almost looks kind of septic. He has this thing called pulsus paradoxus. And what is the most likely diagnosis? I'm just going to mute you all for a second. Someone is trying to reach me urgently. Hey Rahul, I'm just giving a lecture to residents. Can I just
Fahad, do you want to answer this one?
Sure. So it seems like the clinical signs that we're seeing, the pulsus paradoxus, lower blood pressure, sinus tachycardia, and then the distant heart sounds, seems more what we would classically see for tamponade. If we had an EKG, would probably be kind of looking for if there's electrical alternance. But given the recent invasive procedure, I would suspect cardiac tamponade for this patient.
Yeah, that's great. And sorry, I'm just trying to make sure I don't close this off. Yeah, yeah, that's great. Recognizing the complications of ablation is very important and expected because you all will see this, right? These patients will come to the emergency room, and you all will be the first line of care for these patients. So it's very important you all recognize this. It's a very common procedure, atrial fibrillation ablation. We do like, I don't know, 10 to 12 a week here. It's like, it's become so common nowadays. So it'll be very important for you all to know these complications. Luckily, the complication rate at most centers that have a high volume is rare. These major complications is around 1%. The common things we talk about with patients is, the risk of stroke, death, cardiac tamponade, which basically means a perforation with bleeding in the pericardial sac that impedes flow into the heart itself, so that the change in the blood pressure with inspiration and expiration increases. I don't have the time in this lecture to go into the physiology of pulsus paradoxus, but the bottom line is the change in blood pressure increases when the inflow into the heart is decreased. And cardiac tamponade is a very common cause of this pulsus paradoxus. Atrioesophageal fistula is also another life-threatening complication that you all may see. These patients will basically present 2-3 weeks after having an ablation procedure with sepsis and stroke-like symptoms. And so it may show up on the boards, and it may also show up, for you all in real life. I can tell you a lot of these patients don't do well because people did not recognize this possibility. They had a stroke, they had some GI kind of symptoms, and they end up doing a scope for this patient and just make things worse. So trying to recognize this early, doing a CT scan, or referring to a center where they do surgery for this very early is the only way to save a life when a patient has this otherwise life-threatening complication. Another rare complication is phrenic nerve palsy, where the phrenic nerve itself is paralyzed. The right phrenic nerve runs very close to the right-sided pulmonary veins, and sometimes inadvertently this can be affected. That can go unrecognized during the procedure, but patients then show up having difficulty in breathing, requiring oxygen, etc. And a simple X-ray will show you the right hemidiaphragm elevated much more than it usually was in prior X-rays for the patient. And you can diagnose this condition. Usually not life-threatening, but can really alter a patient's lifestyle, especially if it doesn't get better. Other complications, major vascular bleeding, that's usually recognized right away. Pulmonary vein stenosis is something that can present with patients having shortness of breath, usually several weeks to months after the procedure, usually diagnosed with a CT scan. Overall complication rate in terms of minor and major complications is 3 to 5%. We have like few minutes left, so I'm going to speed through the remaining slides here. But in terms of rate control, this is also an option for some patients. especially the very old patients. They are not candidate for ablation or long-term anticoagulation. We can either use beta blockers, calcium channel blockers, rarely digoxin, and sometimes even amiodarone. People have used amiodarone for some reason. It tends to work better with lower drop in blood pressure compared to beta blockers and calcium channel blockers. For some patients, we do see amiodarone used as a rate control strategy. And the last option for rate control is to actually burn the AV node itself. So that it is an ablation, but not a typical AFib ablation. What we do is we put a pacemaker and then burn the AV node, so that now the patient's rate is completely dependent on the pacemaker itself. This should be the last question. We'll try to go through it quickly. This is a 78-year-old male who is evaluated for palpitations, worsening fatigue, and exercise intolerance. 2 months ago, he was diagnosed with atrial flutter and underwent a cardioversion to sinus rhythm. He had an ambulatory ECG monitor that is showing recurrent atrial flutter with an average rate of 69 beats a minute. He has a history of hypertension and coronary arterial disease. So his CHA2DS2-VASc score right there is 2 for his age, and then hypertension CAD is 4. So someone appropriately put him on Coumadin. He's also on metoprolol, lisinopril, low-dose aspirin, and atorvastatin, given his history of CAD. On exam, his heart rate is okay, but it's irregular. Other vital signs are normal. His labs are also not bad. Here's an ECG, which I'll show in the next slide. And he had a stress echo that was normal. His LV ejection fraction is normal, more than 55%. And this is his ECG. Any of the senior residents want to take a jab at this ECG? It's also something you'll see commonly.
Okay, I can talk about it, but just looking at it from the get-go, we can kind of recognize the sawtooth pattern of the P waves. By looking at it in details, we start with the rhythm strip. So the lead 2, you can see the RR interval is irregular, so you can say it's irregular from that point. You can see P waves, but the P waves are, you have like 3 P waves, 4 waves between RS intervals, and they look like this sawtooth pattern. So you can say like this is atrial flutter. And of course, we look for P waves on lead 2, lead 3, and V1.
Yeah, that's great. You guys already know everything. I'm not sure why I'm here, but I'll try to clarify a little more. Hopefully, it'll help at least first-year residents. So yeah, like you rightly pointed out, I don't know if you can see my arrow, but in 2-3 AVF, you can see that there are these negative sawtooth waves. This is very classic, what we call atrial flutter. And then typically, for typical atrial flutter, which I'll talk to you all about in the next few slides, V1 is typically going opposite of lead 2-3 AVF. So if 2-3 AVF are negative, V1 at that same time, if you do a rhythm strip, is going the other direction. And V6 and V1 also are opposite. So this is very classic for what we call as counterclockwise isthmus-dependent right atrial flutter. This is bread and butter, most common, 90% atrial flutters, even in patients with congenital heart disease. This is the most common type of flutter. That is a very well-defined circuit, and electrophysiologists love it because we can do a very quick ablation for this and take care of it. Which brings us to the question, what would you do next? Would you do amiodarone, cardiac catheterization, cardioversion, or ablation? And just in interest of time, I'll just skip over and say that because this patient has already had flutter before, is having already many episodes, he's relatively, not that sick patient that can't get an ablation done. You don't want to put them on long-term amiodarone therapy for something you can quickly take care of. So the right answer is actually catheter ablation. And this is what an atrial flutter circuit looks like. This is looking at the right atrium standing from the foot. This is the inferior vena cava, superior vena cava. This is a tricuspid valve annulus cutout. This is the 3D electroanatomic map. This is what we create when we do these procedures. So you can see there's a circuit going round and round around the right atrium. And what we do is here you can see the circuit shown with the arrows. And we put these lesions with the help of these round dots, as you can see, which are ablation lesions that we deliver along this isthmus or this pathway between the tricuspid valve and the IVC. And when we do that, this flutter typically terminates. And then we also make sure that this line is completely blocked going both ways so that the flutter circuit cannot start up again. Again, we spoke about the typical pattern of flutter. There's also atypical flutter. This especially occurs if someone has had prior cardiac surgery or if they've had prior ablations, and other flutter circuit can set up either in the right atrium or commonly the left atrium. In general, a rhythm control strategy is preferred for these patients, and catheter ablation, especially for typical flutter, has a very high success rate and is a first-line therapy instead of trying recurrent cardioversion or antiarrhythmics. So again, in conclusion, just to give some high points, if patient has a hemodynamically unstable AFib, you want to cardiovert these patients. Again, if you see AFib or flutter, your next impulse should be, what is this patient's CHA2DS2-VASc score and how can I prevent this patient from having a stroke? In general, if patients have non-valvular AFib, you want to prefer NOACs over Coumadin. In young patients, in those who have symptoms despite rhythm control, or if you're not sure if they have symptoms, and especially in patients with CHF, you really want to consider a rhythm control strategy. And for atrial flutter, especially typical atrial flutter, a catheter ablation is the first-line therapy in lieu of recurrent cardioversions and antiarrhythmic medications. Thank you. I'm sorry I went a little bit over time, maybe. Didn't leave too much time for questions, but I'm happy to take questions.
Thank you very much for that comprehensive lecture, Dr. Contractor. We have a lot of budding cardiologists in our program right now, so I'm sure they all really enjoyed this. Does anyone have any questions? Because we also have our next speaker ready, so speak now or forever hold your peace so that we can.
Okay, I have a quick question. It's in relation to patients with AFib presenting with the tachycardia-induced cardiomyopathy. So say this patient comes in new onset AFib, the LV ejection fraction is like 20%. In that stage, I mean, you could consider that they could be an ischemic etiology too. So would you cardiovert the patient and then see if it recovers, or before you consider like doing a catheter, what do you call it, coronary angiography, or would you do at the same time? Like, so what would be the approach?
Yeah, I mean, again, I wish I had like a which we could use for every patient. Obviously, each patient is different. If someone has a lot of risk factors for coronary artery disease, and if the ejection fraction is not improving despite rhythm control and reasonable rate control, it's reasonable to do some sort of ischemic eval. I think we would, what we would typically do is convert them if their ejection fraction does not improve in a reasonable amount of time, like say 2 to 3 months. If the ejection fraction is not completely normal, we would do some sort of ischemic eval. Most commonly nowadays, we are doing a cardiac CT, that gives us a very good anatomy without the risk of invasive procedure-related complications that can happen sometimes with a coronary angiogram. The other thing we look at is the echo itself, right? This is where I think talking to the cardiologist and looking at the body of the echo report is also important. So for example, if the entire LV is globally down, then there's a higher chance of it being tachycardia induced. On the other hand, if there's regional wall motion abnormalities, for example, if the echo report describes the anterior wall and the apex are severely hypokinetic, the rest of the walls have mild hypokinesis or normal wall motion, then there's no reason for AFib to cause regional wall motion abnormalities. It should affect the entire ventricular musculature to a similar extent. And in those situations also, I would be a little more aggressive about doing an ischemic eval. Obviously, if someone already has prior coronary artery disease for having angina type symptoms before as well, even in those patients, I would consider doing an ischemic eval. I hope that answers your question. It's not
yeah, it did. Thank you very much.
We have like a cookbook kind of answer for every patient.